Hello everyone. Today we will discuss about a topic related to nephrology, that is renal tubular acidosis. So, renal tubular acidosis is an inability of the kidneys or nephrons to handle acid and base, that is bicarbonate reabsorption and acid excretion. And it is a normal anion gap metabolic acidosis kind of condition. Then one more important thing is, in this condition the GFR will be normal, that is function of the kidney other than acid handling will be normal. So this is a brief introduction. Now we'll discuss about the types of renal tubular acidosis. So mainly there are 4 types of renal tubular acidosis. So type 1 we consider it as distal. Then type 2 is related to proximal. Type 3 is mixed, both proximal and distal lesion will be there. Whereas type 4 is because of the JG apparatus abnormality. So how to remember this and how to understand this one? See, mainly we have to we should look at like a story of a hostel. So consider nephron as a hostel, okay? And as we know, like few boys are there who will try to damage the hostel. Now what are these agents? Like what are these boys? Considering here mainly some heavy metals, some autoimmune diseases such as systemic sclerosis, SLE, etc. Then some medications, especially few antibiotics and NSAIDs, PPIs, etc. Then some mutations of chloride channel, bicarbonate channels, then some other mutations, especially mutations we can consider here. So these are few agents which are trying to damage the hostel, that is nothing but nephron. So now how to remember this? First, type 1. Type 1 is distal, as we said. This is type 1. So what happens? This is like few students will join the hostel, but when it comes to leave the hostel, they will try to damage the thing, like they will try to break the glasses, windows, doors and all. So this one they are doing at the end. So these are the first type of students or first type of guys. So type 1 is mainly distal. It is at the end of their course they are destroying the hostel. That is what here there will be some abnormality related with alpha intercalated cells. This is type 1. Type 2 people, like boys, will be very rare, we consider. So type 2 RTA is very rare. Why is it rare? Because few of the guys, when they enter the hostel, there itself they will try to damage it. So such kind of guys are very rare. So whatever type 2 is related with PCT, like proximal convoluted tubule. So damaging the nephron at the initial part only, that is considered as type 2, but it is very rare. As we know, it is very rare to see such kind of boys who will damage the things at the entry level only. Type 3 is mixed. So obviously it will be damage of both PCT and distal convoluted tubule or distal part of the nephron. Type 4 is, it is like the glory of nephron, that is JG apparatus. So JG apparatus, this is type 4. So this is like the shan of kidney or nephron. Like whatever the function of the nephron will be there, that will be lost. So this is mainly seen in diabetic nephropathy. So diabetic nephropathy is the most common cause in which there will be loss of function of the JG apparatus. So it will be a hyporeninemic, hypoaldosterone situation. So in this case, kidney or nephrons will not be able to do or will not be able to perform the activities which they normally do. For example, normally there will be absorption of the retention of the sodium and excretion of the potassium and also excretion of the acid. So this normal function will not occur. So there will be loss of sodium in the urine and there will be retention of the potassium and H plus ions. So this will lead to acidosis that we consider as type 4 renal tubular acidosis. So I hope you got the different types and where they will cause the lesion. Now we will discuss about the features of renal tubular acidosis. So how they will present, mainly clinical features. So in type 1, as we can see, there is some abnormality in the alpha intercalated cells. So they will not be able to excrete H plus ions. So H plus will retain in the body. So this will lead to excess H plus. So instead of excreting H plus, now they will start excreting potassium. So this will lead to what? Excessive potassium loss. So obviously there will be hypokalemia. And obviously it is a acidosis condition, so the pH will be decreased. So acidic environment we can see. Similarly in type 2, that is lesion of proximal convoluted tubule. Here what is happening? Here main abnormality is related with bicarbonate absorption. So there will not be enough bicarbonate absorption. So overall level of bicarbonate in the body will be reduced. That will manifest as acidosis, metabolic acidosis. So again, as bicarbonate is an osmotic agent, so as it is getting lost in the urine, along with it there will be osmotic diuresis of many other electrolytes or ions, for example glucose, amino acids, and also potassium. So again in this case there will be, we can list out now. So there will be loss of bicarb, pH will be acidic, then there will be loss of glucose, other amino acids in the urine. Then what about potassium? Again here also, because of osmotic diuresis, potassium is getting excreted, leading to hypokalemia. So this is the feature in type 2. Type 3, mixed type of manifestation will be there, which is also called as marble bone disease. Coming to type 4, here normal function of the nephron is not happening. As I said earlier, there will be no sodium retention, so it will lead to hyponatremia, and instead of excreting potassium, body will, like nephrons will retain it, so it will lead to hyperkalemia and acidosis again. So these are the features which can manifest in renal tubular acidosis. And one more important thing is, whenever there is excess acid in the body or blood, it will try to leach out the calcium out of bones. So calcium will start like coming out of the bones. So this will lead to weak bones, that is osteomalacia, weak bones. And this excess calcium can lead to renal stones, because it will start getting excreted in the urine. So it can lead to hypercalciuria. If it is in excess, it can also lead to renal stones. So this might be the another manifestation of any type of renal tubular acidosis. So now how to investigate? You got it here. Here mainly RFT will be normal, that is urea creatinine will be normal. But when we consider like bony pains in a young individual with normal RFT, we have to consider renal tubular acidosis also. So we have to get ABG done, in which we will see normal anion gap metabolic acidosis, that is NAGMA. Then there will be like changes in the potassium, which will help in differentiating which type of renal tubular acidosis it is. Then we have to look for urine microscopy to find out whether there is associated loss of glucose and amino acids. That will indicate type 2 renal tubular acidosis. So these are few investigations we can consider. Now how to treat? Whatever the damaging agents are there, if we are able to find it out, just we have to treat that particular condition. Or if any like any insulting agent such as heavy metals or some medications, if they are there, then we have to avoid them. In case of mutations, we will not be able to do much, so just treat the like whatever manifestations are there. For example, for acidosis, give bicarbonate supplements, whereas in type 1 and type 2 there is hypokalemia, we have to give potassium supplements. But in type 4 renal tubular acidosis, there is hyperkalemia, so we have to correct hyperkalemia. Whatever electrolyte disturbances are there, we have to correct that. Then there is loss of calcium, so we have to give calcium supplements also. And in type 4 renal tubular acidosis, like it was as because of dysfunction of the JJ apparatus, we can give supplements, that is with fludrocortisone 0.1 mg we can give, so that it can start doing its action. So this is all about renal tubular acidosis. Just remember nephron as a hostel and these causative agents as the hostel guys who are trying to damage the hostel. So just based on whether they are damaging it at the entry level, that is proximal convoluted tubule only, earlier part, which is very rare. So type 2 is very rare. Some guys commonly they will damage the part in the end. So that is distal intercalated cells. That is most common, and this will lead to type 1 renal tubular acidosis. Type 3 is combined, and type 4 is the glory of nephron, that is GG apparatus dysfunction. Most common cause is diabetic nephropathy. Thank you all.